Very good. Skin lesions. This is the only respiratory disease that we talked about in this class that presents with skin lesions, macules and papules. Please do not forget that. What else goes on with these patients? Is it just localized to the lung and the skin? No. Very good. It affects multiple organs. And please keep in mind that you go over the organs that it attacks. What is the issue with sarcoidosis, why it attacks multiple organs and it's just kind of all over the place? What is the issue as far as the pathogenesis here? What happens with sarcoidosis with immune cells? What's the issue? It could be. Eosinophil count could be elevated, but that's not the physiology behind it. Say that again.
Abnormal T cell?
It very good. There's an abnormal T cell. Okay, there's an abnormal T cell function which causes these individuals to increase macrophages. Please understand that if you know the immune system, we know that macrophages come and eat and attack. So if a person has macrophages elevated in all different types of their organs, understand that this is what we call or fall under the category of as an autoimmune response. So these patients do have an autoimmune issue where their body just, they don't know what happens, why the T cells get, off. And now they have an increase in macrophages attacking all these different types of organs. Okay, so just keep in mind the physiology behind that. Now, moving on. Say, for example, if I'm allergic to bird feathers, what respiratory diseases that fall under? Very good. Hypersensitivity pneumonitis. Okay, hypersensitivity pneumonitis. Keep in mind that the risk factors with that particular respiratory disease are, I said bird feathers, but any type of animal, farm. There's a lot of things on the farm, okay, with, as far as that's in the table, the different allergens. And if you look in your book, I can't read this, it's so tiny, table 22-3, it goes over all the different types of allergens. The other thing with hypersensitivity pneumonitis, this is common or predominantly in non-smokers. This is the first time we see this. Everything else is smoking. But this is non-smokers because this is more of an allergic reaction to something particular. Okay, what can you tell me about occupational lung diseases?
Foreign objects and chemicals that are being...
Very good. So this is foreign objects that are chemicals that are inhaled, particles, okay, that can be inhaled into the respiratory tract. Okay, very good. And what else? Anything else you could tell me about occupational lung diseases? When it gets inhaled, it damages something in the respiratory tract, something in particular. Very good, the cilia. It paralyzes the cilia. There are, I think, 1 or 2 other respiratory diseases that paralyze the cilia, and I would tell you to make sure you look those up. okay, just in case if you see a question, which of the following paralyzed cilia, okay? So just make sure you know which ones share that common physiology. What can cause ARDS? What can cause an acute respiratory distress syndrome? Shock. What else? Trauma. What else? Sepsis. What else? Fat emboli. Burns. Anything. Okay. So, and not to trick you, but a lot of things can cause shock. Okay, excuse me, a lot of things can cause the ARDS, okay, because either it can cause it directly or indirectly through shock, okay? So just please keep that in mind, that there are a number of things that can cause the ARDS. There is also a table in your book, okay, that goes over all the different types, and that's table 23-1. Is that it? Oh no, that's different. Oh, I'm sorry. That's different. Oh, they're missing a table. Oh, box, not table, box. I'm sorry. Box 23-1. It's there. Box 23-1, not table. The box is it's a green box. And lastly, what is the issue with IRDS, with infants? Infant respiratory distress syndrome. What is the pathogenesis here with infants, why they have a respiratory distress syndrome? Something that happens at the alveoli level.
Intrathoracic pressures.
Okay, pressure. That's part of it, but it's something in particular with the alveoli that they're not secreting or they're not producing. That's the issue. The issue is they're not producing something that's causing the alveoli to not be functional. Very good, surfactant. These babies are not producing the surfactant that they should. Okay, therefore causing an issue with the alveoli. And then the pressure and all that goes along with it. Okay, hence the reason why the treatment is surfactant. Okay, surfactant is the treatment. Okay. I think we talked about pneumothorax already. Now I'm trying to go over everything that I can go over, but if you see that I'm missing something, please make sure that you read all your PowerPoints, read even the sections in your book that go with that particular topic so you can get a full understanding. Okay, so now week 6, we did chapter 36, well for you guys, 36, 31, and 33, okay? The other 2 classes were off. Okay, so for 36 GI disorders, I believe that this chapter is very, very straightforward. This chapter really, some of the other chapters can kind of piggyback with each other, so like cardiovascular, respiratory can kind of get intertwined. Obviously, vascular disorders can get intertwined. But when we talk about GI, GI is pretty much on its own. The only thing that can get sort of intertwined here with GI is cellular adaptations, okay? Those are present in some of the GI disorders. And when we talk about necrosis, necrosis can also be present when we talk about the torsion, okay, of the intestines. So, one major thing I just want to kind of throw out some questions to you. When we talk about gastritis, chronic gastritis, I should say, chronic gastritis, peptic ulcer, and gastric carcinoma, what is the #1 risk factor? Very good, H. pylori. Don't forget that.
What were those three? Gastritis.
Gastritis, chronic gastritis, gastric or peptic ulcer, and also gastric carcinoma. Okay, they say the #1 risk factor is H. pylori. Don't forget that. Honestly, like I told you, I look at a lot of different NCLEX books to make questions. And I saw that question in every NCLEX book that I took a look at. Okay, so make sure you know that H. pylori is the culprit for that. What is a complication of GERD? Yes, the reflux of acids, but what's the complication, the other condition, I should say, with the esophagus? Very good, Barrett's esophagus. So Barrett's esophagus is a complication of GERD, and if a person gets Barrett's esophagus, what is the complication that could happen after that? Metaplasia, which could lead to esophageal cancer. Okay, so metaplasia, which they're concerned of that leading to esophageal cancer. Very good. What is a hiatal hernia? You don't have to tell me the different types, but what is it? Okay, when the stomach pushes up through the hiatus, and this comes from the diaphragm being weak. Okay, now what could cause the diaphragm to be weak? Old age, very good. Heavy lifting. And abdominal pressure, sometimes obesity or pregnancy. Okay, so just keep that in mind. Those are some things, and I believe that's in your PowerPoint. What's the difference between ulcerative colitis and Crohn's disease?
Ulcerative colitis affects the colon, and then the Crohn's disease affects a portion of the colon and the ileum.
Very good. Very good. It's the location. Please don't forget that. Ulcerative colitis and Crohn's disease have two different locations. Okay? So ulcerative colitis affects just the mucosal layer of the colon and the rectum, whereas Crohn's disease affects, is an inflammation of all 4 layers, but it's the terminal ileum and portion of the colon, the proximal portion of the colon. So it's right where the, I don't want to say ileocecal, but the small intestines meets the large intestines.
But both have bloody diarrhea.
Yes, they both have bloody diarrhea. Ulcerative colitis has more bloody diarrhea, but Crohn's could have it. But if you see bloody diarrhea, let me just say this though. If you see bloody diarrhea, think of ulcerative colitis. Because usually in those books, it's usually more for ulcerative colitis. Okay, what can you tell me about appendicitis? Right there. McBurney's point, yes. Right lower quadrant, pain. Okay. What else? What other types of symptoms would these patients have other than pain in that area? Fever, very good.
Nausea,
Very good. Nausea, vomiting. They will be very sick, very ill. Okay.
Tender.
Tender, very much tender in that spot. And what happens, there's a test. I don't know if it's on here. Rebound tenderness. Did I put it in here? I don't know if it's in. Oh yeah, there's a test. I don't think it's not on the PowerPoint, but there's a test for rebound tenderness. If you put your hand in and pull out, they're gonna feel a lot of pain. Okay, now, say for example, just to kind of get the juices going, if you have a patient that has an appendicitis and that appendix bursts, so say it ruptures. Now keep in mind the appendicitis, they do believe that it could be caused from maybe fecal matter got stuck in the appendix, okay, and causing this sort of inflammation process. Now, if it bursts, what happens now to the abdominal cavity? It will get infected. Very good. These patients will have what is called a peritonitis. Okay, so now all of that stuff that came out of the appendix is now floating around the peritoneum, and they have a peritonitis. That peritonitis, all of that infection, I shouldn't say infection, well, it is an infected peritoneum with maybe, let's just say bacteria or whatever. If that goes untreated, just to kind of let you know, this could lead a patient into having a sepsis, okay, because now that can spread all through the body, okay, if it gets to that point, but usually doesn't get to that point. Now, we all know what a diverticulum is, right? Okay. Now, what is the issue with IBS, irritable bowel syndrome? What is the cause of it that they say is the main cause? Stress, anxiety. Okay, so IBS, stress, anxiety. Make sure you remember that. Now, I'm quite sure you know the difference between a volvulus and an intussusception. Do you guys know the difference between that? Okay. Now, celiac disease or celiac spruce. What is the issue here?
Intolerant of gluten.
Very good. So people are intolerant of gluten-containing foods, okay? And the reason for that is because of what? They're lacking on the intestines. What is it that they're lacking in the intestine wall that doesn't allow them to digest gluten? Lack of enzymes, and in particular, which type of enzymes? Brush border enzymes. Brush border enzymes. Does that sound familiar from physiology? No. Brush border enzymes. Brush border enzymes, just to remind you, I don't know if you went over this in physiology, those are the enzymes that help break down carbs, okay? In particular, your disaccharides. So this is the enzyme that is the issue here with patients that have gluten allergies. Make sure you go over the treatment for celiac sprue, okay? Keep in mind that yes, they have to stay away from gluten foods, which we know that, but because of that, they do have to supplement, okay, with a whole bunch of vitamins because they're lacking a good amount of nutrition. Okay, now the cancers are pretty easy. I'm not going to go into that. The last thing I'll go over with you is dumping syndrome. What is the issue here with dumping syndrome?
Malabsorption.
Very good. These patients have a malabsorption issue, okay, which means what? So say, for example, you have a patient that went in, had the lap band done. Okay, so they had the lap band, and once they're done having the lap band, what would you do? How would you manage, even though you guys haven't had any classes yet with protocol, but just from your common knowledge, what would you do with a patient as far as telling them what to eat and how to eat that just had this type of surgery? Small meals. Small meals is number one. Okay, number one, obviously patients that have the lap band can only eat small meals, but they definitely have to eat small meals because of this whole dumping syndrome. Now, the dumping syndrome process, if you don't remember, they'll eat the food, glucose will spike, okay, very high, but then what happens is that they call this dumping because they don't have an absorption of the nutrients in the glucose as they should. So then it just kind of goes right through the GI tract, and then they have what is called the hypoglycemia, so rebound hypoglycemia. So their glucose levels drop really, really low. When a person has a very low glucose level, and this is where I'm adding in the glucose testing too for this as well, why I told you to highlight that. When a person has very low glucose, as you know, when patients go into a hypoglycemic state, what happens? They get fatigue, okay, very good. They get, what else? They shake, they get jittery, okay. You guys should have, I'm hoping you probably went over this a little bit in physiology, I don't know. But these patients can really get very ill once they get into a hypoglycemic state, okay. So then what happens here again, you would have to instruct them on eating small meals, okay, and the small meals are every 1 to 3 hours, okay, to make sure that they get the proper absorption, number one, and number two, to make sure the glucose levels are regulated, okay. So that's the reason for the small meals at every hour or so. Okay, so just make sure you go through that. Okay, so that's it with 36. 36, I think, was everyone comfortable? That was your test today. I looked at the grades. What happened? Okay. Please make sure, and this is one of the reasons why I'm giving you guys extra time for the final, and also another reason why I'm going to have the printed exams for you so you can write on and do whatever you need to do. Please make sure you take your time and read the question. I honestly feel that you guys know the material. The material's not hard. I think it's just being able to answer the questions. So take your time with the questions. Don't rush. Don't rush to try to get the answer. I am giving you an extra 30 minutes to get through the final. Okay, so you'll have time to go through and take your time with whatever questions you need. Okay. And when I say take your time with the questions, go over the answers too. Sometimes people pick answers that, if you see an answer that is what is called like a negation, so say for example the answer has, let's say the person in the question, in the answer says the person has low blood pressure, high blood pressure. Well, that's an oxymoron. How can it be high and low at the same time? So we know that that should be X'd out. Okay, and then you go to your next answer, the next answer, okay? So even if it's one part of that answer that is correct, if you see another part that's wrong, that's not the answer, okay? So it's just a matter of breaking it down. Okay, so the last two chapters that we're gonna go over, which we went over last week, 31 and 33, so male and female reproductive disorders. Now, this information should not have been that difficult. I don't think it's hard. Let me just point out the topics that you should be focusing on because there were some things I cut out, so I just want to make sure you have the right thing. So with male reproductive disorders, the first thing we talked about was cryptorchidism. Now with cryptorchidism, which we know is hidden testes, what is the complication with this? Infertility along with cancer. Very good. So infertility and testicular cancer, those are the main complications with cryptorchidism. We went over hydrocele, and we also went over spermatocele. Hydrocele and spermatocele. Okay, so those two things are easy to understand and know what they are. But what diagnostic testing could be done to distinguish the difference between the two? Something I talked about in class. Very good, ultrasound. Okay, so an ultrasound will be able to distinguish if that is actually fluid or if it's sperm. We also talked about testicular torsion, and we went over in detail the treatment for that. We also went over epididymitis. What is the causative agent for epididymitis? Very good. So the STDs. So the STD bacteria, whether it's chlamydia or gonorrhea. We talked about Fournier's gangrene. And we talked about testicular cancer. And we talked about BPH. I think most of this stuff is straightforward. It's nothing really. Make sure you know the treatment for BPH, because it's a possibility that I could put the meds on here. And the meds are actually quite easy to memorize. It's alpha blockers and 5-alpha reductase. And if you know what an alpha blocker does, you know what the alpha, it actually, if we're blocking the alpha receptors of the mechanism there, we're actually blocking the muscle, okay, from contracting. So to reduce the tension. The other things we went over was prostatitis. And with prostatitis, make sure you go over also the routes of entry. So remember, prostatitis is mainly like a bacterial infection to the prostate gland. But there's different routes of how that bacteria can get there. And then the last thing I think we went over was prostate cancer. And that was it for males. With prostate cancer, the test that is done for that is the PSA. Okay, so remember the PSA along with the imaging, ultrasound, and things of that nature. Did anyone have any questions with that chapter or any other chapters? Yes.
It's a question that corresponds to the test.
Yes.
There's something about the BPH, and it says forceful urinary stream. It gives options which ones to pick. I guess it says on there that it's wrong to put that slow. What was it? Slow urinary stream. It's like oxy to me. Frequent or forceful and slow. How do you?
Okay, what was the answer? I have to look at, I don't remember what the answers were, but I'll pull it up. I'll pull it up. Just give me a second. Let me just finish this and I'll pull it up. Okay, now, chapter 33, we went over female reproductive issues. And so we started right in the beginning here, and I think we stopped at endometriosis. I think that's where we stopped. Okay. So amenorrhea, so in the beginning, there's just terminology, and I do need you to know the terminology, and I think we had one or two questions on today's test with those terms. So make sure you know what it means with amenorrhea, dysmenorrhea, menorrhagia, metorrhagia, okay, so all of the rheas and rhagias. The other thing that we talked about, we went over in detail uterine prolapse, so obviously go over that. And I will possibly have pictures of the 3 different types or the 3 different levels. Displacements of the uterus, which we had today on the test, so we had a picture of one of those displacements. Know the difference between a cystocele and a rectocele. PID. And what is PID? What is that usually associated with? STDs, okay, so they usually associate PID with STDs, so chlamydia and gonorrhea, much like when I talked about prostatitis, okay, that is more associated with the I'm sorry, not prostatitis. What was the other one? I'm confusing myself. Epididymitis, thank you. Epididymitis, not prostatitis. Epididymitis is associated with the STD, whereas prostatitis is more bacterial infection. Okay, so PID for females, and that's also for gonorrhea and chlamydia. And vulvovaginitis, what is the issue here? What is the cause, most common cause?
It could be irritants or bacterial infection.
Okay. Well, most common cause, but it is that could be part of it. Thank you. Thank you. Yeast infection, Candida albicans. Okay. And then yes, some other things like gonorrhea, herpes, and other things could cause it too. But that is the most common. Okay, is Candida albicans. We talked about barthololysis, and then we also talked about fibroids. Okay. What is the issue here with fibroids? What is the cause? What do they think causes fibroid production?
Increased estrogen.
Very good. Increased estrogen. So they believe that increased estrogen is the cause of this. And then we also talked about ovarian cysts. Then we also talked about endometriosis. Please make sure you know that endometriosis has a cellular adaptation of metaplasia. Okay, so it does have a cellular adaptation of metaplasia that they believe that happens in the uterus. And I think that's where I stopped. Any questions about the material? I tried to give you as detail as I could with the final. I hope this is good enough. Let me say this, please make sure that you review all of the PowerPoints, okay? Please make sure you review not only the PowerPoints, but even in class when you guys take notes, make sure you review all the side notes that I give you for the subject. Make sure you review all the pictures, obviously all the laboratory values. How I would tell you to study for this, same way you've been studying so far. Please try to get creative and make your own case studies that can incorporate maybe 1 or 2 diseases, because that's what I'm going to do for questions. Use the questions from your book. I don't know if many of you are using them, but go to the website and use those questions as practice. If you need practice questions, I think the only new material, I think you guys have all the practice material for the chapters, maybe with the exception of reproductive. If you need that, I can go and get them for you. Do you have practice questions for 36 for GI? Some of you may have got it from